Just to introduce myself, I'm Kirsten Rose-Felker. I'm one of the pediatric cardiologists here, and I specialize in heart failure and transplant cardiology and have worked on transitioning a lot of our patients to the adult side. I have the pleasure of talking about this topic, safe contraception and chronic disease conditions, and have no disclosures except that this topic is definitely out of my wheelhouse, and I think learning more about this and being present to help answer questions or provide some information to you has really been helpful for me as well. So the role of the pediatric provider in contraception, I think these are sobering statistics. As we know, many of our adolescents report special healthcare needs, and sexuality and associated healthcare needs may not be addressed in this population. And while about half of students reported ever having sex in a survey in 2011, many without adequate counseling from the medical field, data supports similar levels of sexual behavior in this complex medical needs group. The role of our pediatric group is to just help guide adolescents and young adults through this by obtaining a sexual health history, screening for pregnancy and sexually transmitted infections, and counseling. If indicated, our role is also to provide access to contraceptives. And this statistic I found very hopeful. Adolescent pregnancy and unplanned pregnancies has decreased significantly from the 1990s to early 2000s. A large portion of this is attributable to increased contraception use in this population. There's many reasons that contraception can be provided to adolescents and young adults, and I think this is a really easy way to start this conversation because it might be a little bit uncomfortable for some of our patients. We have to remember that dysfunctional uterine bleeding, acne, dysmenorrhea, and then menstrual suppression of menstruation may be all indications to provide these medications and forms of contraception. So how do you bring this up? I think for me, this can be one of the hardest things. We recommend using motivational interviewing, which is really asking our adolescents and young adults to ask us what they have, what they're going through or what their thoughts are, listening and avoiding judgment. We can focus on their goals, values, and relationships. For example, if college completion is a goal or ongoing participation in sports is a goal, we can really kind of use that to frame how would an early or unplanned pregnancy or having a sexually transmitted infection impact these goals. And then confidentiality is a huge barrier. A lot of adolescents and young adults may be unaware that these conversations are protected as confidential information. And it actually may be one of the reasons that they forego healthcare altogether or choose to not talk to us about contraception. So this is how I feel when we get to the point where an adolescent or young adult needs contraception is, where do we start? Especially if you have somebody that's taking other medications or has other medical issues, where do we go from here? So I think if you break it down by why are you using contraception, that may be able to help a little bit. And then I'm gonna highlight at the bottom, there's a CDC guide to contraceptive needs in people with medical conditions, which I think is incredibly helpful. And I included the link, which I think should be available to you on my slides. But are we using this for pregnancy prevention? And do you need to consider if your patient is interested in having return to fertility in a short period of time? Is it STI prevention alone? Are there specific medical concerns? So I think one place to start is just really understanding how effective different methods of contraception are in preventing pregnancy. You'll see on the left-hand side is typical use and on the right-hand side is perfect use. The difference between these, typical use is, this data is obtained by national surveys with users that have varying levels of adherence or taking the medications or using these methods in a typical situation versus perfect use is if these are data obtained from clinical trials where there's a lot of supervision and surveillance to make sure that that methods are being used consistently. So we can see here, I think if you use a single method of contraception alone, for example, condoms, the rate of unintended pregnancy in the first year of use is quite high. And so I think we really need to consider, since many of these are not available without a prescription in the state of Pennsylvania and our surrounding states, that as healthcare providers, we really need to help our patients do better. So I'm going to give a quick overview. And again, I am no means an expert in this, but this is an overview of some common methods of contraception. So starting with progestin implants, these are, it's an implant that's inserted in the non-dominant upper arm. And this is a single progesterone-eluting rod. And these are highly effective. They can remain in place for several years. This is something that can be done in a routine clinic visit. The insertion of this typically takes a minute, and removal can be a little bit longer, but really in the realm of minutes. These are safe in women with estrogen contraindications. So these may be women that have blood clots or other medical conditions. They're good for those who have trouble adhering to a regular schedule. And I think all of us can relate to having trouble adhering to doing something every single day at the same time. These can often reduce uterine bleeding and periods, which may be a pro for our young adults. The cons is that the most common reason for discontinuing these in young adults is that you may have spotting or irregular menstrual bleeding. Experience in the first 3 months of using these is best predictive of the future use of how that side effect is going to be. And so it's definitely worth counseling individuals who are interested in this form of contraception that this may be an issue. And then some people report emotional lability, acne, headaches, and weight gain. It's also important to remember that we counsel our patients that abnormal uterine bleeding can also be a sign or symptom of a sexually transmitted infection. And so that's something they should bring to our attention. Intrauterine contraception, or IUDs, this is a long-acting reversible contraception. There are 3 different forms that are FDA approved in the United States, and these prevent fertilization by inhibiting sperm motility and thickening cervical mucus. There were prior concerns about the use of IUDs in young people who have not had children, having potential issues with future fertility. This has been largely discredited and thought that some of the association in some of those earlier studies may have actually been more related to sexually transmitted infections. So that is no longer a concern. In terms of pros, these are very safe and effective. The failure rate is less than 1%. And worldwide, this is a major form of contraception that is gaining popularity in the US. People tend to be highly satisfied with these, although we have less data on our younger patients and adolescents. These can lead to improvement in dysmenorrhea and even amenorrhea. These can be helpful for long-term menstrual suppression for that reason. Patients will need to be screened for sexually transmitted infection at the time of insert of one of these. There's a small increase in pelvic infections if there's a current sexually transmitted infection, but the risk of that after 20 days of insertion is not increased due to the IUD. There are reported high rates of expulsion and discomfort on implant in women who have not had a child. And then we're very lucky here at Children's that we have pediatric providers who are trained in placement of these, but this may be a barrier for some of our providers in the community, that this may be an access issue, as you may have to find a provider that's willing to insert this. Contraindications for an IUD are a current or recent pregnancy or pelvic inflammatory disease. As providers, we are able to treat sexually transmitted infections and deal with this on a subsequent visit. And so this is something to really talk to providers about. These are the 3 that are approved in the United States. The Paragard or copper IUD is the one on the left side. This has the longest approved use. And then there are 2 progesterone, releasing IUDs, the Mirena and the Skyla, which are approved for 5 years and then may be effective up to 7 years, and then approved for 3 years at a lower dose of progesterone. Depo-Provera or progestin injections. This is a long-acting progestin that's given as a single injection every 13 weeks and can extend up to 15 weeks. This can be delivered intramuscularly in a clinician visit, and there is more investigation that's ongoing about self-administration with subcutaneous injections. These can be used any day of the menstrual cycle, even if pregnancy can't be ruled out, and often in that case, there's a recommendation for a pregnancy test a couple weeks afterwards. These are also good for those of us who have trouble adhering to regular schedules, and they can improve dysmenorrhea and protect against iron deficiency by decreasing uterine bleeding. These are also safe for people with most chronic illnesses and can have additional benefits in medically complex individuals, like raising seizure threshold or decreasing sickle cell crises. Cons of these, there's a possibility that these could increase the risk of DVT, but the benefit outweighs the risk in patients that have a history of clots. Again, with a lot of these hormonal contraception, there may be menstrual cycle irregularities that will improve with time. And then I think it's the need for repeated injections and ongoing follow-up with the provider that can be a reason to not use this for a long time in some individuals. There is, I think bone mineral density is probably the biggest thing to cite here. This is something that should be considered on our patients that are on chronic steroids or have other risk factors for bone disease. Although there's 3 prospective studies that have been done in adolescents showing an early return to bone health after cessation of these. And there's no recommendation to routinely follow bone health because of that. Combined oral contraceptives, this is the most common form of contraception in the United States. For adolescents. These all contain, these are combined estrogen and progestin supplements, and you can use higher dose or these low dose forms that may be a good way to start our adolescents. These are reliable and effective, but require regular use at the same time every day for the best efficacy. And these are available by prescription in the United States. So it's important to counsel our minors that it's possible that if this is being prescribed through an insurance plan, this could result in notification of the family. And so this is an important discussion for our adolescents to have with their families and for us as healthcare providers. We always recommend a backup method with this because there is no protection against sexually transmitted infections, but certainly for contraceptive purposes in the days surrounding starting these. And then adverse effects, you can have transient or irregular bleeding, headaches, nauseas, and then blood clots are one of the reasons that people are most afraid to use these. Contraindications are severe and uncontrolled hypertension, hepatic dysfunction, complicated valvular heart disease, migraines, complicated diabetes, complicated solid organ transplant, and some certain bleeding and clotting disorders. Although it's worth noting that the risk of clotting in pregnancy outweighs the risk with all of the combined oral contraceptive pills, and this should strongly be considered. In terms of prescribing these pills, there's a whole lot out there. Some of the common things that you may hear of, there's monophasic versus phasic, which means that the dose of the hormones may vary throughout the month. Typically, these are prescribed in a 28-pill pack with some placebo pills that you may see here. And these can reduce acne, decrease menstrual cramping, decrease blood loss. And some of the newer pills may be packaged without any placebo pills for extended cycles. And those can really be helpful in those with heavy bleeding issues or conditions that are exacerbated by cyclical changes. There are medications that our patient population may use that can decrease the efficacy of these, and this is important in counseling our adolescents and young adults. And then the contraceptive vaginal ring or NuvaRing ring. This is a estradiol-related ring that's inserted into the vagina and protects against pregnancy for a month. This is round and flexible. It's recommended by the AAP that we use a model or a diagram when we're using this form with adolescents to just kind of demonstrate proper use of this. It's a simple regimen. It can be used the same day start as the clinic visit, and it's considered to be bone neutral with unclear data about clotting risk. Adverse effects of anything with all contraceptives really can be breast tenderness, headache, breakthrough bleeding, and nausea. And then the transdermal contraceptive patch, or ortho-evra. This is a hormone-eluting patch that's placed on the upper abdomen, torso, outer arm, or buttocks, and one patch is placed for 3 weeks in a row with a 1 week off period for breakthrough bleeding, although continuous use can be used. The estrogen exposure is higher than in some combined oral contraceptive pills, and there's an increased risk of thromboembolus, not significantly higher than combined oral contraceptive pills, but also something to strongly consider. And these may be associated with a high risk of discontinuation. Side effect profiles are very similar to combined oral contraceptives, although there may be some local skin-related effects too. And then the progestin-only mini pill. This works by thickening cervical mucus, and this is recommended for ongoing use to take very consistently. It can be used before a sexual encounter takes place as well. These are generally considered less effective than combined OCPs. Irregular bleeding is a common adverse effect, and these are generally not recommended as a first choice in healthy adolescents. Male condoms are something that we should be providing and counseling patients to use every single time, despite prescription contraceptives. These are the best way to prevent sexually transmitted infections. They can be, they're available in both latex and polyurethane. Natural condoms should be discouraged because of their poor ability to protect against sexually transmitted infections. And these are easily available and don't require a prescription, so it should be something readily available. And then I just want to spend a minute talking about emergency contraception. There are a few different forms available of emergency contraception. The levonorgestrel or progesterone only form is the one that you see on the right, the Plan B one step. It's important to note that this may lose efficacy in women that are over 165 pounds. And so this is worth counseling about that. It is available for women over 17 by the FDA without a prescription, although this has been challenged in some states recently. Also, there are additional forms of emergency contraception that are available, and these are most effective that are used within 5 days after unprotected sex. The sooner the better. The reason I want to talk about this is something that an advanced prescription should be considered in people with chronic health conditions, because data supports that this does not increase their risk-taking behavior and may really help in a situation that was unplanned. And there are no medical contraindications. When looking at just some kind of quick big medical conditions and what are some considerations, in our population with obesity, we talked about how emergency contraception may be less effective. In addition, the transdermal patch may be less effective as well. We need to remember that metformin and bariatric surgery can increase ovulation and increase the risk of fertility or increase fertility, and that we really need to think about using it in these situations. In patients with HIV, antiretroviral agents may have interaction, and then condom use should be used regularly for prevention of transmission. For those with solid organ transplants, typically we would recommend a period of organ stability, largely because there may be drug interactions, especially with combined oral contraceptive pills, although there's no contraindication to using them earlier in that period. It's recommended to avoid estrogen in patients with coronary artery disease. And this is really a population that we should consider discussing emergency contraception. And then in the oncology world, we've talked about extended use of some contraceptive pills or other forms for heavy menstrual bleeding, bleeding disorders, or with chemotherapy. And then I'm going to end. There's a really great, in this article published by the American Academy of Pediatrics in 2014, there's this really great resource within there, in addition to that CDC document, going through with a lot of resources that may be available to print in your clinic or have when you're looking to prescribe these forms. All right. Thank you. I'd be happy to take questions as part of the panel.
Hi, everyone. I'm Malamo Countouris. I'm an adult cardiologist, primarily based at McGee Women's Hospital, and I also do a little bit of time at Presbyterian Hospital. I'm going to be talking to you today about high-risk pregnancies and specifically heart disease in pregnancy. So you'll see my talk will focus specifically on heart disease, but I think you'll find it applicable if you have, other diseases of other organs. I think the sort of framework of a multidisciplinary team caring for you during pregnancy will be applicable. So I'm going to start first by talking about why we care about heart disease in pregnancy. And kind of the focus of the talk will be about the multidisciplinary team that we use at McGee and is used at other institutions, where we have we call a cardio obstetrics team. So basically not just cardiologist, a subspecialist caring for individuals during pregnancy, but also collaboration with our maternal fetal medicine providers and other subspecialists as well. We'll talk about what medical conditions we treat, how we assess cardiovascular risk in pregnancy, and then a little bit about timing. So when is the best time to see your subspecialist to talk about pregnancy, and then throughout sort of the pregnancy and postpartum timeline. I'm going to start by setting the stage, and this slide is not meant to scare anybody, but I do want to highlight that we have a problem with maternal mortality and morbidity in this country. In the United States, we see increasing rates of maternal mortality over time in the past about 20 years. That is different than other developed countries. We see actually decreasing rate in most other developed countries, but the United States, we're doing a particularly poor job of caring for women with cardiovascular conditions and other conditions with rising maternal mortality rates over time. This is contemporary data, so it spans from 2018 to 2021. You'll recall that covers a time period of COVID-19. And so some of these increased rates probably are related to COVID. And you can see on the y-axis, I am showing maternal mortality rates, and it's kind of divided by race and ethnicity. This has been all over the news, so I don't think it will be surprising to anyone that we see more than double risk of death for Black women when we compare to other races and ethnicities. So particularly for Black individuals, we need to be doing better. And then when we break down by why individuals are dying in relation to pregnancy, there's a lot of this is from cardiovascular causes. And I think that's why it's particularly of importance that we as cardiologists are paying attention to this. So I've highlighted on the left-hand side of the screen the more common kind of causes of maternal mortality being hypertensive disorders of pregnancy, cardiomyopathy, and other cardiovascular conditions. Black individuals in particular are affected by these cardiovascular conditions and are more likely to die from those. Why do we think we're seeing, maternal mortality and morbidity related to pregnancy? Well, essentially, pregnancy is a 9-month stress test. If you can imagine, individuals now need to supply blood not just to themselves, but also to the fetus. And in order to accomplish that, we increase cardiac output. So literally with each squeeze, the heart is pumping more blood. That's an increase in stroke volume. And we also see an increase in heart rate. These are the kind of hemodynamic changes that we see also with exercise. And so it's sort of like a 9-month stress test, if you will. The heart actually goes through changes during pregnancy to increase that stroke volume and cardiac output. The heart muscle thickens, the heart muscle dilates, the left ventricle dilates, and these are normal changes in pregnancy. But for people who have already underlying cardiovascular conditions, some of these adaptations that the body needs to make are much harder, and sometimes result in adverse effects and sort of inability to tolerate the pregnancy state. On the right-hand side of the screen, I'm just showing the percent change from pre-pregnancy in each of these measures of cardiac output, stroke volume and heart rate. And if you look at the sort of slopes of the lines, the biggest change are happening in that kind of 8 to 20 weeks of pregnancy, really majority happening in the early second trimester. We see the biggest changes. And so if we're going to see symptoms develop, oftentimes we'll see them start in kind of the second trimester or late second trimester of pregnancy. I'm going to talk a little bit about our multidisciplinary team, but before we do, I wanted to just give a very brief overview of some of the conditions that we treat. This is not an exhaustive list, and I've divided by congenital heart conditions, which are ones that people might be born with, and then acquired heart conditions that we think, develop throughout the lifespan. But I'm, listing some of the common congenital conditions that we see, and then on the acquired heart disease side, we see people with heart failure, cardiomyopathy, coronary artery disease, higher risk conditions like pulmonary hypertension, and on the congenital side, things like systemic right ventricle or aortopathies, really require a comprehensive kind of risk assessment prior to pregnancy and very, very close management during pregnancy if pregnancy is not contraindicated. So here are some key components of our multidisciplinary team. Of course, we have, sort of the cardiologists that specialize in care for women during pregnancy. These are what we call sort of cardio-obstetrics cardiologists. Our adult congenital heart disease specialists also care for individuals during pregnancy. We partner very, very closely with maternal fetal medicine specialists. So we actually, have direct lines of communications happening all the time between cardiology and maternal fetal medicine, whether that be via text, via email, via messaging in our electronic medical record, sharing notes. And then when we think about delivery planning, we need to involve our anesthesiology specialist as well to help us figure out, adequate pain management, timing of delivery, mode of delivery. And then I have on here also our nurses and our advanced practice providers, which are pretty key in helping us deliver the best care that we can. And all of these team members are present. Once a month, we have a multidisciplinary virtual meeting where we talk about each of our highest risk patients, and we kind of go through in detail the risk assessment, timing, management during pregnancy, medications, cardiac testing, and then timing and mode of delivery. So it's not just one individual making these decisions. We decide as a group what is safest for each of our patients. This is our cardio-obstetrics team, some key players, and you'll recognize, I think, some of these faces from today. From the adult general cardiology side, we have myself, Dr. Kozo, and Dr. Berlacher. We all see patients at McGee in our Women's Heart Center. On the adult congenital side, we have Drs. Saraf, Wolf, and Hoskapel. Dr. Ricky Hansra has a unique kind of training background. He's a critical care cardiologist, so he sees patients in the ICU, but he also has some training in cardio-obstetrics. So for most sick patients during pregnancy, he provides expert guidance for us. And then on the inpatient side, we wouldn't survive with two of our nurse practitioners, Kim Bollinger and Kirsten Weber. They help us see all of our inpatient consults. And they actually keep a running document where we have each of our patients, their conditions, their recent testing, so that if we ever need to, if we have a question on some of the discussions that have happened in the past about a particular patient, they have that all documented and saved within our UPMC system. So what do we discuss when we have our multidisciplinary team meetings? I mentioned this. The first is sort of cardiovascular risk assessment that may be associated with pregnancy. And on the next slide, I'm going to talk through how we assess cardiovascular risk. Follow-up intervals are really important. So talking about when we need to see you back during your pregnancy, and that will span from pre-pregnancy all the way postpartum. After delivery, we still want to be seeing patients and making sure they're not developing new issues. For some patients who have really, mild disease, we only see them once or twice during pregnancy. And for some people who have more serious conditions, we will see them once a month. Medication management is really important as well, because there are some medications that we have our cardiac patients on that are not safe in pregnancy. And we want to make sure that we stop those because they could affect the fetus if you get pregnant on them. So talking about stopping them and making sure things are still optimized before pregnancy is really important. And then during pregnancy, we might need to titrate medication. So for example, as somebody that has an arrhythmia and is on a beta blocker, we may need to increase that during pregnancy if we see arrhythmia symptoms or arrhythmias manifest. And then I mentioned a very important part of what we discuss is delivery planning. So typically, if it's possible and if it's safe, we like patients to deliver vaginally. That has a lower bleeding risk. It's better for the fetus and better recovery for mom. So there's some nuance to that because some conditions are too high risk to deliver vaginally. So all of that we discuss in our multidisciplinary meeting, the modality of delivery, the timing, and collaboration with our anesthesiologist about how to do it. This is something called a CARPREG risk score, which is one of the risk assessment tools that we use to evaluate cardiovascular risk in pregnancy. And it basically assigns points for the highest risk conditions, the conditions that are associated with the highest risk during pregnancy. And then you can sort of sum a score and assess your percent predicted likelihood of having a cardiovascular event during a pregnancy. So you can see here, if you've had prior cardiac events, that's going to put you at high risk. If you have baseline heart failure symptoms, particularly at rest, or if you're hypoxic at rest or cyanotic, that increases risk. Mechanical valves are risky because patients are on anticoagulation. And without that are at high risk for blood clotting, which we sort of previously learned is high risk during pregnancy and with estrogen. And then there are other conditions that are more moderate risk that can increase your risk score. One of the things I wanted to point out here down at the bottom is something that is within our control, and late pregnancy assessment is associated with higher risk. That makes sense because if we're not able to see you pre-pregnancy or early pregnancy, we might not be able to optimize your condition. And so I think that I just wanted to highlight that piece and give the message that coming to see your doctors early when you're thinking about pregnancy, not later during pregnancy, is really a key piece of us ensuring success during the pregnancy. In this risk model, cardiac events were anything from maternal death to arrhythmias to heart failure, blood clots, myocardial infarctions, or vascular dissection. When is the appropriate time to meet with your providers? I would say now. It's never too early. And just like, sort of as we heard about earlier, talking about transitions, this is something that you want to bring up early and often. So even if at the first discussion you say, I'm not thinking about becoming pregnant now, but sometime down the line I do want that, then that opens up the conversation so we can give a little bit of anticipation. What will we need to do as we get closer and closer to the time that an individual wants to get pregnant? And the things that we would talk about are things like pregnancy risk. When is the right time? And how can we optimize health prior to conception? We want to screen for other risks, factors, or comorbidities that we might be able to manage a bit better. Things like obesity, diabetes, high blood pressure. And then that gives us a time to do pre-pregnancy testing if we need to. Sometimes that involves a stress test or cardiopulmonary exercise testing, cardiac imaging like echocardiograms or cardiac MRI or CT. Some of those things we can't do during pregnancy. So if we need them, we want to do it pre. And then we talked a bit already about medications and kind of the optimal timing. How do you get connected with us at the MIGI Women's Heart Program? We see some patients by self-referral, so please feel free to reach out to us. This is our scheduling number. You can also request an appointment online. And then through your current doctors, we love communicating with people's doctors and making sure that We see people at the appropriate time. We will work people in. So, pregnancy is time dependent. It's not the kind of thing that you can wait 6 months to see the first available provider. So we understand that at the McGee Heart Center. And if you talk with our schedulers in our front office desk, we will often add you on to our schedules to make sure we get you in that time appropriate setting. On this slide, we already talked a bit about how important it is to come and see us pre-conception. In this slide, I wanted to also show that the 4th trimester is an important time too. So classically, we think of 3 trimesters of pregnancy, but after delivery is important as well. And we will often see symptoms manifest at that time and up to 1 year postpartum. To highlight that, this figure shows when we can see 2 specific complications, cardiac complications of pregnancy, arrhythmias and pulmonary edema. You can see in the blue, the arrhythmia likelihood is the number of events are highest in this 2nd and 3rd trimester. That makes sense from what we know about the physiology, because that's when we're going to see the biggest change in need for cardiac output. And so that can manifest cardiac symptoms during pregnancy. But pulmonary edema or heart failure is commonly seen, if we see it, it's going to happen in the 3rd trimester or after delivery. So you can see in the red, kind of the red bar is high in that first 1 to even 6 weeks postpartum. Why is that? Well, if you consider after delivery, you've delivered the baby and the fetus is, the uterus is now sort of clamping down. So we see a whole bunch of fluid re-enter the maternal circulation at that time, and that can promote the development of heart failure for people that have underlying cardiac conditions or who are prone to develop heart failure. So really, really important to be monitoring for symptoms after delivery. What do some of those red flag symptoms look like? Things like chest pain, shortness of breath with laying flat or orthopnea, lower extremity swelling, tachycardia if you're passing out, headache, visual changes can be a sign of preeclampsia, and then certainly fluctuations or changes in blood pressure, whether that be low or very high. I want to give this figure as a conclusion slide, and it's from a JACC article on team-based care of cardiovascular disease and pregnancy. And this model of care goes from preconception to postpartum to long-term. So we really think about almost like an individual's whole lifespan, and pregnancy is one piece of that, but we want to prep for it prior to conception. We take very close care during pregnancy through multidisciplinary team management. And then postpartum too, we want to see you, we want to be monitoring for symptoms and optimizing medications and ordering testing if we need to. We can't do this in a silo. It really takes a village. So as cardiologists, we can't do this alone. And it's the same for the other subspecialties too. We have to partner together with the obstetricians, the maternal fetal medicine specialist, with the anesthesiologist. It takes a whole big team of us. So thank you. And I'll take any questions as part of the panel.
All right, good morning, everyone, or almost afternoon. I'm Orquidia Torres, and I am faculty within the Division of Adolescent and Young Adult Medicine, and I'm here today to talk to you about gender and sexuality. So you may question why I have this slide up, Spider-Man Into the Spider-Verse. I don't know who has seen it, or if you have seen it already, but not to give too many spoilers, this movie was released a couple years back, and it talks about or goes over the main character, Miles Morales, who gets bit by a spider and becomes Spider-Man. But in the process of this movie, Miles has to essentially decide whether he's going to become Spider-Man or not. And a lot of that has to do with whether his parents are going to accept him, his friends and other people around him are going to be okay with him becoming Spider-Man. And in this scene right here, he is taking the leap of faith because now he identifies as Spider-Man and fully takes on that role. He also finds out there are other spider people in the Spider-Verse. Now, fast forward to just a couple of weeks ago, Spider-Man Across the Spider-Verse was just released. And in this movie, Miles obviously already identifies as Spider-Man, but he finds out there are way more spider people than he ever knew about before, which are in the background of this picture. There are spider women, spider men, spider animals, which you would have to see the movie if you want to get a better understanding what I mean by that. But in both movies, what they're hinting at, and why I like it, even though it doesn't really bring up the concept of gender and sexuality, it does bring up a concept that all our young people have to deal with, which is figuring out who they are, figuring out their identity, figuring out what they want to be, who they want to be, and who they want to be perceived as. And that is a process all our young people have to go through to and achieve to complete adolescence. But when we think about our gender diverse youth, that process is complicated by all these other stressors that we see on the slide. They are trying to figure out their identity for themselves and internally going through that. But then they have family members, maybe even school members, peers, who may also add to the stress and increase the impact on their mental health. But we know that when our gender diverse youth are supported, their mental health is less impacted. And so why is this important? So I just want to dive a little bit into the prevalence of gender diversity. And so when we look at a study in 2017 that looked at young people across the nation and how they identified, we see that about 2.7% are identifying as transgender. But that seems like it's underreported, because in 2020, our former fellow, Dr. Kidd, did a study in our fellowship program looking at data across the Pittsburgh public schools and found that about 9% of of teens are identifying as gender diverse. And so it also depends on what the kind of questions you're asking. And so to better understand how this is impacting our young people and how to better support them, let's dive deeper into the definitions of sex and gender. And so we're going to talk about sexual orientation and attraction, sexual development, gender identity, and gender expression. The term sex refers to the binary classification of male or female, and this is usually assigned at birth based on the external genitalia. The term gender, while it can be changed for, or often changed for sex, it really refers to a person's internal sense of behavioral or psychological or social traits. Sorry. And then gender identity is a person's internal sense of being male, female, both, neither, and gender expression is how they show themselves off to the world. A way to really depict this is the flying gender unicorn, or you may have seen the genderbread person, and it goes over all the details of what we're going to talk about. Sexual orientation and attraction, who and what we're attracted to. So sexual identity is describing a person, how a person identifies as. So that can be lesbian, gay, straight, queer, and then their behavior is who they're intimate with. And a person's sexual identity does not correlate with their behavior. So for instance, a person can identify as lesbian but have male partners. Sexual orientation and attraction. People can be attracted to one gender or more than one gender. They can be attracted to certain traits like intelligence or kindness. And the type of attraction can be different, doesn't necessarily have to be physical. It can be emotional or romantic. And then sexual development and biological traits. So we mentioned this earlier about the female and male identification that's assigned at birth, but there are people who are born in this intersex category where they have ambiguous genitalia. And for gender diverse people, they do not want to be defined by their anatomy. And this is just another depiction of that, particularly in the intersex category, where there's a continuum of biological traits. And so a person may not necessarily fall into the typical female or the typical male. Gender identity. So we mentioned this earlier, but a gender identity is an internal sense of being binary, which is male or female, or non-binary, a mix of masculine and feminine, or neither of these. And because this is internal, one's gender identity is not visible to others, and so it's important to ask. Cisgender, that person identifies with the same sex that they were assigned at birth. Transgender is different, they identify with a different sex that they were assigned from birth. And this kind of encompasses all the aspects, with whether it's trans men or women, agender or non-binary, or a mix of that. And the non-binary can include or exclude elements of masculine or feminine gender identity or expression. And they may or may not identify as transgender. Some other terms: genderqueer, this is kind of similar to non-binary. Gender fluid means that a person's gender identity is not fixed in one realm, whether it's a trans woman or a trans male. It depends on how they're feeling and what they're going through at the time and how they want to present. And then agender, kind of also similar to non-binary, where they're not identifying with male or female. To give a better depiction of what that looks like on a graph, this is an XY model, and it shows where the binary identities are on the scale, but also where the non-binary identities are. Another depiction is the transgender umbrella, and this shows you the binary and the non-binary. And so when patients come to us in adolescent medicine, a lot of times they're coming because the way they identify becomes a problem with how they're feeling and what they do on a day-to-day. So an example would be if a person is identifying as trans male, but they have periods, they may want to come and see us because they want to get rid of the periods or do something to help with the periods so that they don't have to deal with that, because it's impacting their mental health and other things around them. Gender expression. So this can be different. It doesn't really matter whether they identify as a certain gender. They may want to dress a certain style or present themselves in a certain way. And so again, it's important to ask what a person identifies as, because it's not necessarily what's in front of you. So you can't necessarily assume that a person identifies as male if they dress as a male. And then gender transition. So this is some of the steps that we do in our clinic to help a patient and their family feel better and improve their mental health and their goals for their future. And it is a conversation. Sometimes it's many conversations with the parent, with the patient, and having a team, our social work team, our therapists. Sometimes we need psychiatrists and the adolescent medicine doctors, and maybe even other doctors, to help kind of decide what can be done to help with this patient. And the patient also has a lot of say in this and what they are comfortable with. And so for some people, they just want to do a social transition. And that can be just changing the way they dress, changing their hair, or the way they speak, which is reversible. For others, they want to consider doing a medical transition. So one example is using a puberty blocker like Lupron, which can block the effects of puberty, especially if that is making a person stressed or feeling anxious or depressed, that they're going through puberty in a body that they don't identify in. And then a person can also consider gender-affirming hormones like estrogen or testosterone to help really align with their identity. And again, that's a conversation with patients, with parents, and the providers, all taking care of this patient to decide when we do that. And usually that's an older teen. And then we go forward from there. Surgical transition, this is more complex than it seems on this slide, but again, this is for older teens, young adults who really want to proceed with further steps to align with their gender identity. That may be top surgery, that may be bottom surgery, facial surgery, or voice surgery. And finally, I want to talk about how we treat these patients and teens and young adults when they come see us in clinics, in hospital settings, and other settings in your day-to-day life. So you want to find out their chosen name. So for instance, my name is Orquidia, but my chosen name is my nickname, which is Kiki. And that goes for anyone. Doesn't matter if they identify as transgender or not. It's important to ask what a person prefers to go by. Ask about their pronouns. Again, this is not something that where you're gonna know by looking at a person. So you wanna ask them either at the beginning of a visit, or even if your staff is able to get that information in the beginning in the front desk, if they're willing to share that information. That's important to know so that everyone can call that patient by their preferred pronouns. And then if you misgender, it happens, and yes, it's a mistake, but you want to correct yourself in the moment, apologize, and move forward. If we dwell on that or we make a big deal on it, especially in a visit, that can make the young person feel even more upset or hurt by this. How do we support a young person? So when they come to see us in adolescent medicine, again, we find out what they like to be called, their pronouns. We like to know what they want as their goals for the future, and what they want to do to be able to get that to that point. Who's supporting them? Who can we help to get support for them? A lot of times, again, those visits can be multiple visits in a row, kind of talking to the parents alone, talking to the patients alone, talking together, and involving other providers in their care to help that patient. And then educating parents, you want to provide support for them too. They're going through a lot too. They may be confused, they may be angry or upset for whatever reason, and you want to hear those concerns. So it may mean pulling a parent to the side and talking to them, and it doesn't matter what office or specialty you're in. Depending on if a parent wants to talk about that or if a patient wants to talk about that in a different setting, you can, or refer them out to a different specialist who's able to handle that. And finally, to make an office friendly, LGBTQ friendly, you can train the staff, make it a safe zone for patients and families. And we said this before, but asking about names or pronouns, having signs that show that we are accepting in our clinic space or office space, and asking permission, whether this is okay, it's okay to say these pronouns or say these names in front of family members, patients, and other people. And with that, I will conclude.
How do you rely on resources within our hospital system to get around those situations where you don't have the expertise?
I can start. So I think it's important to find that out for everyone, because these patients are going to show up in any specialty clinic, not just adolescent medicine. And if you know what they like to be called, what pronouns they like to use, they can feel better respected in that setting with you, even though you do not do that type of care. Now, if you bring that up and you ask that question, and then you feel like you're going down a rabbit hole, you can say, hey, this is not my expertise, but I'm willing to, and I want to help you, I'm willing to help you, and so I want to refer you out, if you want that, to specialists that can do that for you. And you can definitely see them and still see me for ongoing care for various concerns.
I think we take that approach on the subspecialty side as well, and I really appreciate that question, because cardiologists generally are not well trained in talking about contraception or talking about pregnancy or gender issues. cardiologists really feel uncomfortable. So the approach we've taken in cardiology is to try to educate our peers. So we talk about these issues at our conferences that span UPMC, like across, multi-state, because it has to be universal. We really feel strongly that every cardiologist needs to feel comfortable with at least opening the conversation. And similarly, if they need, more advanced cardio-obstetrics care or approach, then we see them at McGee. So we'll very often, see people at McGee during their pregnancy, a little bit postpartum, and then we'll transition them back to their kind of general subspecialty providers.
Yeah, I agree. I find a lot of benefit of explaining to families the first time I meet them that I'm going to ask to see the adolescent or young adult alone, because I think that's a huge piece that seems so straightforward, but a lot of us forget to do. I think also just kind of, as I mentioned in the talk, is really just trying to get a sense of open-ended questions, like what are your goals? What are you struggling with right now? What's difficult for you? You're not going to be able to address everything at every clinic visit, but I think really just being open-minded and finding ways to work these topics into their set of goals are